Welcome to CareTalk, Bruce. We've all been through an awful lot with COVID. And one of the interesting things about COVID from a healthcare perspective is there was a lot of acceleration and innovation. What do you think are the most important accelerants and innovations that should stick? And what have we learned from that period?
Yeah, I would say there's probably, when you sort of classify the innovations, maybe you put them in two different buckets. One is around the holistic care, really looking at the individual in a much more broader fashion than just the treatment that they need at the particular time, and I'll come back to that. And then the second is convenience, is the ability for us to have a much deeper thought process around how do we make it convenient for people to obtain care. And so just to build a little bit on that. On the holistic side, we do see growth in the areas around like behavioral health has become really important. And so it's just not about the health of somebody, it's about obviously their mental health. We see a lot of that. Social determinants of health have become an active part of that. But in addition, we're also seeing interventions that are much more oriented to the individual. So, managing diabetes and other areas like that, which was important, but it's become much more important because it's much broader than just the treatment of diabetes. It's really the ability to keep the individual stabilized. The second thing that we've also seen is obviously the use of technology in healthcare, and we've seen it in a few different ways. One is around the convenience, so virtual health is there. Virtual health and behavioral health has obviously been an acceleration over the last few years. Virtual health and with telehealth has been growth. Virtual health, telehealth, and the assisted with a nurse or some technician in the home is an example of that. So the expansion into the home has been there. And in addition, we also see growing opportunity in remote monitoring and the use of technology there. And then on the technology side, you also see this ability to utilize AI and machine learning, and that's probably an area where I look at a great growth going forward as the identification of more context around the individual, their clinical context, but as importantly, how they engage. And I think today, one of the challenges of healthcare is less about the science, but which science is greatly evolving. It's more around how do you engage with the individual.
And so what the new era of artificial intelligence has been announced every 5 years for the last 30. What's different this time, and how are you using the data you have in a different way to engage with consumers and patients?
And I would say, established organizations that have been around a long time, that have technology that is somewhat dated, so I hate to say this, but we still have COBOL level programs in our organization, and it's been
so does every health insurer in America.
Right, that's right, and that's really it. And so you have to evolve the technology platforms that you have, and that we've invested in a lot of that. And that evolution is utilizing the power of the cloud, not so much from a storage point of view, but the ability to have the power to do AI. And so, for example, we today have an AI that is taking images that we receive from practices, because the interoperability is not an area where it's fully deployed in the healthcare system. And we digest that image and turn it into usable data that is then used to create an expert system on behalf of our clinicians to make decisions. And that amount of data that is being crunched, all the way from being able to convert it from a text image to usable data, and be able to do that in a way that is dealing with the nuances of the medical language. Some people call it one particular disease, another will call it another disease, or it might be a particular treatment, and being able to utilize that takes a lot of compute power. And what we've seen is being able to do that in the cloud and be able to ramp up and ramp down that cloud. And so what I've seen in our company is the ability to get to a more contemporary platform, that you have the data lakes, you have the cloud-based computing, and then in addition you have the analytics capability to do it. Really is the combination of those are important, as opposed to just one of those.
And the real benefit of that then is humans out, machines in. That it allows you to actually bring down your cost per transaction.
Yeah, I would.
Is that really the biggest edge?
I would say that it allows individuals to do something at a higher level than they could do before. And so, we're taking the use of the work that I was just mentioned, and a clinician could spend 45 minutes on a particular intervention. Today, they're being able to do it in 4 or 5 minutes. So yes, our costs are coming down. It's a more enjoyable job for them, and in addition, it's much more effective for the ultimate outcome that we're trying to obtain. So we find it's a win-win-win for everybody. Mm-hmm. It really is.
And how have you used AI to engage with members differently? Because
these are not part of the questions.
No. We're going to go into
off strip here.
And you're surprised?
Yeah, that's true.
So you early on were very thoughtful about the psychographic profiles and the archetypes of the different consumers and patients you have as a way for Humana to meet patients where they are. Have you used AI in that to engage with patients differently?
We do. I mean, we are constantly trying to learn about the individual. And as I mentioned before, there's multiple levels of learning. One is just the context they're in. And what I mean is, what's in their home, what really is important to them, what are areas of clinical need they have, and then what interventions they have, and then in addition, how do they want to engage? Meaning, do they want somebody to come to the home? Do they want to go to the office? Do they want to do it over the phone? So there's a whole host of contexts, and that's where we see AI being most effective. Now, I would say we have a long maturity of this. We're early in this cycle, and I think healthcare is early in this cycle, but I think this personalization to engage with individuals is really a great opportunity for healthcare overall because it's contextualization. And, I know we always talk about Amazon and how they order books and so on. I don't want to be disrespectful, that's a fairly simple context.
Very simple transaction.
Because they know what you ordered last time, and now you need to put it, what this is something you would buy now. When you think about the complexity of healthcare and all the different aspects of it, whether it's your wealth or health or where you live and what your preferences are, it's really complicated. But I look at that as the really great opportunity for healthcare in the long run. And that's why I talk about this holistic care as being much more important because you're able to get that context.
Well, and now that I work at Walgreens, please feel comfortable, insulting Amazon as much as you'd like.
Sure, there you go. I did that on purpose, actually.
So you touched on interoperability, and we've talked a little bit about that back and forth over the years. Where are we on the road to an interoperable system, which is a frustrating it seems like a technology problem that only healthcare can't solve, but is solved in all of the other parts of our life, whether it's
it's been talked about a lot, but I'm very bullish on the opportunities over the next 5 years or so. And the reason for that is I think the FHIR interoperable API has brought some standards to it, and it can be evolved and so on, but we find it as a very helpful aspect of that. In addition, I think some of the regulations are putting the industries and the payer industry, the provider industry, in a necessary need to advance. And I think that push is really, really important. I remember a number of years ago when Seema was the head of CMS, she was really pushing interoperability. And I remember sitting in the Roosevelt room, and she got us together with the president and really was pushing. And she asked, I said, you just need to make us do this. Rewards and all the other things aren't going to do it. You just need to make it, and it's the right thing to do for the industry. And I know it's painful for all of us, including us as a company, but it's wrong to have fragmented information and people not have access to it. And so I think the regulations and where we are today is pushing us not as fast as I'd like to see. But I do believe it's an opportunity for payers and providers to come together deeper. We have been working with Epic over the last, I think, 36 months now. We have about 100 hospitals now that are on the Epic plan that we are putting information in the workflow on pre-authorization, the ability for the...
in real time?
In real time, and drug orders to be incorporated in the workflow so that someone doesn't someone understands the cost of their drug at the time that it's being dispensed, as opposed to when they get to the drugstore.
Okay.
And I didn't say order it online or something like that. And I just feel the opportunity to remove friction in the system, to improve the experience for the member, and frankly and the patient, and in addition to reduce the cost of both the provider and payers. I just feel the interoperability is there, and I would love to see the healthcare industry push that deeper. And when you look at industries that have really advanced the flow of information, like the financial services sector, I mean, can you imagine what that's allowed for innovation and development, and the inefficiencies that it's taken out of the system? And so I just look at that as a great opportunity where everyone wins at it. And I just feel, and I hope the industry will have the same perspective that we have, is push it and help the industry become much more connected.
Well, I'm not sure your optimism is warranted, given the fact that healthcare has fought it, kicking and screaming each step of the way.
Yeah.
But you've actually used data and information to hook yourself more closely to providers and provider systems. What does that mean for the patient? Like, what happens when you are as integrated with either your physician groups or your hospitals in a way that you think makes the most sense, in addition to saving money
we
on
do it a
drugs?
few ways. I mean, one is just in the flow of information we offer our value-based payment relations, that we really want to give them information so that they can understand how to manage risk. And frankly, that's been a tenet of the company really since we owned hospitals and we were a staff model. I mean, we use some of the same architecture in being able to do that. So that the ability for providers to take risk and manage risk, and then utilize the information, whether it's information that we provide them a cloud-based system if they don't have one, or for many of our more sophisticated value-based relationships, we will incorporate it into their workflow so that they then can utilize it in managing risk. So that's one area. The second area is really around how do we help them in areas like STARS on the quality side, or risk adjustment and other areas like that, where we can provide some help to them in being able to understand what things need to be done. So if this patient is coming in, it might not be a value-based relationship, but if we can provide them the information about the patient, the next time they come in, ask them about an eye exam or a particular cancer diagnostic or something like that. So the ability to continue to share information to allow the better care
creates a better patient experience.
Yeah.
And have you seen differences in performance where you're providing the data and providing the tools?
Yeah.
Like, well, what would be good examples of that?
Today we see value-based relationships with information that we provide, being able to have, about 25 to 30% better STAR scores. Their net promoter score is significantly higher, and their cost of care is significantly lower by about 10 to 15%, we see. But the other thing on the interoperability side, and this is what we do for our members, just to build on that, is that we actually, if you go on to our website this time of year and you want to look at a plan, if they authorize us, which isn't it's the blue button method that CMS came out with a while back, we will take their Medicare claims, and we will bring it in, and we will then run the analysis to bring back what is the best plan for them. What drug usage they have, what doctors they see.
To the person, based on their particular history.
It takes about 20 seconds.
Wow.
But that's an example where power is really
data
putting into the individual user, and that for them to then be able to utilize that to personalize it, is the power of bringing the information across the platform of healthcare into an area where it's precise for the individual.
And are you building all that technology yourself? Because effectively you then become a tech-enabling, sort of enterprise for providers.
We do. I mean, obviously we use partners to help us with that, but we have a lot of capability internally. What we have found over the years is with really good partners that can offer the technical support, and then we then have the business knowledge, the combination of those two help.
So you touched a little bit on risk adjusters, which has gotten a lot of attention recently, certainly with my friends at Cigna. Any comment on the status of risk adjusters and kind of the future of them? Because there's obviously a fair amount of regulatory interest, and yet people have a variety of health backgrounds. I mean, what's your view of it, and how do we get it right?
Yeah, I'll try to be salient in my answer there, because there's so many levels to that. And just for the audience, the risk adjuster within Medicare is an important element of Medicare Advantage, and it's important because it allows companies like Humana to be oriented to the higher acuity patients. I always say Medicare Advantage is an upside down insurance, because you're incentivized to take the more unhealthy. And I think that's a wonderful opportunity. And with guaranteed issuance.
And it wasn't always that way.
Yeah, no, I remember when Medicare Choice was around. But it's a great opportunity because it really allows you to engage where individuals are needing it the most. And how it was developed based on a comparison to Medicare fee-for-service, both in how they determine the rate, but also the error rate. Because the accuracy of risk adjustment in Medicare fee-for-service is very low. And it's that error rate is why people are getting in trouble, the compliance side is oriented to there is no error rate. The payment side assumes there is an error rate. And that sort of difference is what is creating this sort of void in the healthcare system. And what you see challenges like Cigna and others, United is in there, Anthem's in there, that there's just this misunderstanding. And I believe that we got to get this corrected, because and when healthcare has this grayness to it, nothing good comes out of it. And that's really what the industry is trying to work with CMS on, and we're hoping over the coming year that we'll be able to get this solved. But the lawsuits that you see and the investigations from the Justice Department are wrapped around that perception of, is there an error rate, or is there not? And the system was set up based on an error rate.
And do you get to a level of Medicare Advantage participation where you don't need risk adjusters anymore, or where it becomes more general population?
I think I do believe we're approaching that opportunity there, but there's still 60% of the population that is represented in Medicare fee-for-service, and you need to have that some reflected in there. But there is an evolution that I think could happen to that.
So, Bruce, you're saying a lot of great things about government, like in terms of pushing interoperability.
And I'm not running for election.
and you're being very balanced about risk adjusters. Government regulations, Washington right now, force for good or ill for healthcare?
It depends on where. I can say some areas probably need more regulation. I won't go into that. And then other areas probably less regulated. I've been in healthcare for a long time, and it's an area where is it governmental provided or is it private provided? And those partnerships between private and public can get complicated, and eras go and come in that. And I think you have to live with the regulation that's there. I have found over the years that when it is practical, there are removal of regulations that happen, and when there is need, it eventually gets there. And so I will be very diplomatic and not say that everything needs to be unregulated and everything needs to be regulated. I think in the business that we have and do, there's a responsibility to a broader population, and that responsibility, I think, is also needs to have some regulation to it.
But some of the things you touched upon, like the regulations loosening.
None of these questions were in this. I mean, we are.
I'll ask you what I said.
I don't
okay, let's pick on something that would be fun.
Please continue.
I'm surprised you didn't come back to there's a lot of pushback on virtual care post looking towards the end of the public health emergency, and potentially a lot of the state and local restrictions coming back. Do you want to comment on that? Because obviously I think it's been a boon in some ways for connecting, particularly hard to reach patients like those who are suffering from behavioral issues.
And this is where payment models that really encourage quality and cost demonstrate the durability. In our business, when someone's on value-based, it is more around what is best for the patient as opposed to what's the most efficient way. It's more what is the most effective way. What is the most effective way from a cost of care point of view, and how do we prevent downstream cost, and from an experience and quality point of view. And I just feel if the more we can get payments that are bundled together that represent a cost and quality, these sort of, well, am I going to do it inpatient or am I going to do it outpatient? Am I doing it in the home? Am I doing it in the virtually? Those become less of the question, because it's not about, okay, I get paid this way and this is how I sort of have to do it. We see it in the home health business today. We own the largest home health company. And we bought it not because we wanted to be in fee-for-service home health. We bought it because we believe intently on that home is a place where it can provide convenient care, better outcomes as a result of it, and it has to evolve. And so one of the big things we're pushing for is much more value-based payment models in the home. And so I understand that there can be a maximization of value because it's sort of this churn, but we have a philosophy that if it is really the right thing to do for the patient or the member, and from an insurance point of view, then let's make sure we're finding the right payment model to do that.
Well, and obviously you're not going to argue. I'm not going to argue with more care to the home. That's obviously what we're trying to do both at CareCentrix and at Walgreens. But do you think that's a threat to the traditional models, the traditional institutional models of where people get care?
I think it has. Sure, every change has a threat to somebody. But if you think, beloved Clayton Christensen, I think, had a very simple model that he always, he can boil complicated things down to simplicity. And I remember having dinner with him one night. He says, Bruce, if you just make 2 bets in healthcare, you'll be right. And the first is, he just said, there's structural change happening as a result of payment changes and technology. Those are 2 enablers that's going to cause change. And what you'll see is it will become less specialized. More will be done by more generalists as a result of the things we were just talking about, AI and all the expert systems that can be created from there, and the ability to, radiology is a good example of that. You can take images and facilitate a much quicker analysis of it. So it's going to move from specialists, I'm not saying specialists are not important, it's just less need for specialists, down to even digital self-service. And that push is going to be a continued trend. And so that's who does it, and where it's being done is the second part. And it's going to continue to be the institutional settings. Not saying that institutions won't, there will always be a need for institutions, but the care will continue to get pushed down to ultimately the home and self-service. And again, it depends on what kind of care you're getting. And if you just took those 2 trends, it is going to happen. It's because of payment model change, technology, and so on. So you can fight it, and fight it as long as you can. But the trend is there. Now again, it's not everything's going to home, and not everything's going to a CNA. But the ability to continue to push that down is the right thing for the healthcare system. It's the right thing for the patient because it's more convenient, and frankly, it's the right thing for us as an industry to continue to push.
Well, one of the things that did come up in our prep call is sort of the disconnect between people who see a system that costs too much and they want to get paid more, and the patients and the taxpayers who just can't afford what they're getting today. And I thought that you want to get into what you see the challenge of solving that cost, quality, and care.
There's a host of different. McKinsey, has done a great study on this, and breaks down where the inefficiencies are. But one area that's, I think, just a great opportunity for payers and providers to come together is the inefficiencies of the system from an administrative point of view. And we've talked a lot about interoperability today, but to continue to work together as a partnership to take the cost out of the system from the point of view of automating, of connecting, of being able to use the sharing of the information to make downstream and upstream decisions much easier. And I think they estimated there's $300 trillion or $400 trillion in the system that is there that we can take out. And I think, Sam Walton, early in his years, he went to the vendors, so to speak, and said, listen, let's work together to take the inefficiencies out of the system and utilize technology to do that, and logistics and the efficiencies of the logistics. And, for all of us, we benefited from that. We had a lower cost of goods for us that the prices came down. I just feel there's a wonderful opportunity for the industry to do that, and I think we're at the cusp of it as a result of the technology that's rolling out, and frankly, the pressures we're all facing as an industry.
Well, speaking of those pressures, how are we going to solve the drug pricing conundrum? I mean, when you and I started in our careers, hospital costs for commercial payers were one of the biggest costs, and now it's drugs. Drugs are just dramatically outpacing, and it's not just the cool new biologics; it's the stable chemical compounds. I mean, as one of the biggest purchasers, and as well as owning a PBM, what's the solution?
Yeah, there's multiple levels there. I mean, obviously the development area is one area, and I think the opportunity to continue to utilize the efficiency in drug development, I think we have a great opportunity to do that. In fact, I was talking to a CEO. I got an investment document a number of weeks ago from somebody that was raising money, and they were taking AI and the ability to recreate cells and putting it in a wafer, and being able to not have to do animal testing anymore, and could do thousands of testing in this wafer. And it was just amazing. And talk about just reduced cost and reduced time was an example of that. So I think there's efficiencies there. Obviously, the drug pricing is ultimately where it comes down to, and I think you're going to continue to see pressure put on pharma companies to not utilize U.S. as the most profitable area as we subsidize the rest of the world. I just see that. Obviously, the bill that was passed in the fall the summer of this year is an example of that, where now, certain drugs are going to have to go through.
So you're supportive of that. So we start to have a little bit more pressure on.
And then the distribution area, the PBM areas, will continue to be under pressure. For our PBM, since it's mostly Part D, in fact, it's 99% Part D and Medicare Advantage, we have to put all our rebates back into the insurance pricing. So we don't make any dollars off of the rebates, which I think is a healthy exercise. I think the commercial business is going to move to there, that it will come more into either the rebates or to the point of sale. Now, it's evolving to the point of sale. Before, our rebates subsidized the insurance side, and the people that were utilizing the drugs paid more. Now it's going to go back to the individuals that utilize the drugs are going to get the benefit of the rebate, and the insurance will ultimately go up.
So, can you as a payer put pressure on pharma, or does it have to be the federal government?
We can to a certain level because of just our ability to design plans and move share based on that. But when it's a single source drug, especially in areas like cancer and others, it's really hard. It's really hard, and so price. I think the Alzheimer's drug that was priced, 18 months ago or 2 years ago was an example of that. That was $50,000. Someone has to say, is that reasonable or not? And a number of studies came out and said $7,500 was the. Again, I don't know if it's 50 or 7,500, but there has to be some regulation around that.
Yeah, no, and it's. So last question, Bruce.
You have 35 seconds.
You're approaching payers as a value-based partner. What's your pitch to payers, to providers rather, as to why they should work with Humana in the way you want to work with them?
A few things. I think first, if you want to walk before you run within a value-based payment model, Medicare Advantage is the best opportunity. It's the most mature. It is the most comprehensive from a point of view of sophistication, and the chronic nature of patient populations really fit well to that value-based model. When you get into episodic and treatments in the younger population, it's a little harder, but it can be done. But the chronic conditions really make it a much more effective way to start with value-based. So first, since we are basically a Medicare Advantage company, we've in many years of this, we have an expertise that we can help people. The second thing, we do feel our responsibility is for people to be in the surplus. What that means is you're making more money than you would be in fee-for-service. And so actually one of the things we measure our teams on is are our providers in surplus? Not just how many people are in Medicare, that are in value-based, but are they in surplus? And so we really take their success into account, and that's why we invest in technology, information, and people to help them facilitate that. And we do have a fundamental belief that the healthcare system is not going to be solved by one company. It's a series of partnerships that are really going to...
Team game.
That's right. And so if we can facilitate that, both in payment, in resources, and in addition in philosophy, we feel successful.
Awesome. Well, thank you, Bruce, for this special episode of CareTalk, and thank you, EMIDS, for sponsoring us.